Hello, I'm Mirella Cameran-Reilly, and I'm delighted to introduce you today to the Hamptons Health Hotline. The Hamptons Health Hotline is a new program brought to you by the Southampton Hospital Foundation. The Hamptons Health Hotline is hopefully going to be a new resource for the community we serve, you viewers in East Hampton. So we really are happy that you've joined us today, and we look forward to a great show. We really want to make sure that in East Hampton you're aware of the great doctors operating in your community, the experts who are tackling the biggest healthcare concerns that exist: cancer, heart disease, diabetes, tick-borne diseases. We want to know from them what the newest thinking is, what the best treatments are, the newest clinical trials and drug therapies, and most importantly, how we can reduce our risk. The other way the hotline will work, we hope, is that you will get in touch with us. And it's a hotline to us to tell us what you're worried about. What are the health issues that keep you up at night? So please, get in touch. You can find us on Facebook, Twitter, Instagram, at the handle Southampton Hospital Foundation. And please tell us what questions you have that we can answer in future episodes. Today's program is called Affairs of the Heart, and I'm delighted to have with me today Dr. J.P. Reilly. Now, J.P. also happens to be my husband, so this is definitely a personal affair of the heart today. But the reason he is here is because we are tackling heart disease, and February is Heart Health Month, and there's a lot of important information that we want to get through and learn about. So let me turn over to JP, Dr. Reilly, so he can tell you about the many, many years he spent studying to become an interventional cardiologist and how we ended up in Long Island.
Oh, okay. So my training, I started at Columbia for medical school, which is 4 years of school after finishing college or university, as you like to call it in England. Then after medical school, I did training at NYU. And after doing internal medicine residency and cardiology fellowship there, I did 2 years in San Diego. We then spent 16 years where we started our family and had our kids in New Orleans, Louisiana. And we had a great life there and career there, but it was time to come back home because I'm originally from the Northeast. And so I joined Stony Brook about 1.5 years ago, and which has brought us out here to the Hamptons.
It has indeed. Now I have some statistics about heart disease or cardiovascular disease. Apparently in 2020, 800,000 people will have their first heart attack. And I think it's nearly 500,000 people who've had one heart attack will have another heart attack. It is something, sadly, I think we all know about from personal experience too, hearing of people, knowing people who have died of sudden heart attacks. It's the primary cause of death in New York State. It's the primary cause of death on Long Island. I think it's the latest statistics tell us that over 7,000 people died of a heart attack on Long Island in 2015, and that equates to about 3,500 in Suffolk County. Given that we know quite a bit, or some of us more than others, about cardiovascular disease, why is it still such a problem for Americans? And have you seen a difference between heart disease in Louisiana and heart disease out here on Long Island? And tell us about those differences, or why it's better or why it maybe is worse.
Well, I think that heart disease is multifactorial. Right? It's not just one thing that we can say, this is the cause of heart disease. I think that in some degree, because it is so prevalent, right, because so many people have suffered from heart disease of one form or another, a lot of people come to think of it as just sort of a condition of aging, the same way my hair has gone gray, right?
It has.
Thank you very much. But it's not, actually. There are lots of people who get to be 70, 80, 90 years old who have normal hearts and completely normal coronary arteries. So it is not just the the price of
aging.
I was going to say the price of freedom for the Americans. But right, it's not just a consequence of growing older. As our country has become more obese and higher prevalences of diabetes, the prevalence of heart disease has increased. Now, I will say that down in Louisiana, which is frequently ranked in one of the least fittest states in the country, and with some of the highest prevalence of tobacco use in the country, and obesity, I think the risks for heart disease, particularly atherosclerosis, cholesterol-related deposits in the arteries, was much more significant than here I've seen at Stony Brook and here in Southampton, actually.
Okay. What is heart disease? We talk about that just generically.
Yeah. So heart disease can be used as a catch-all, possibly, to include several different forms of disease related to the heart and vascular system. Heart disease would include high blood pressure or hypertension. High blood pressure is very common and affects 1 in 3 Americans, actually. Probably 1 in 3 of those people with high blood pressure may not yet know that they have high blood pressure. And 1 in 3 of those people with high blood pressure are not getting treated completely to the goal that they should be. So high blood pressure is one of the most common cardiovascular diseases. I mentioned coronary artery disease before. I think that's the thing we think about most commonly. We think about people having heart attacks, whether you're watching ER or watching Fred Sanford coming down the stairs on the Fred Sanford show from years ago, having a massive heart attack when people have blockages in their heart arteries or some other artery that causes a problem. And stroke would be the other big one that would be included in cardiovascular disease. With high blood pressure and coronary artery disease, when they have injured the heart muscle, when the heart muscle can't function as well as it should, that can then lead to heart failure, which would be the sort of fourth class of cardiovascular disease.
So you said that people aren't being treated enough perhaps for high blood pressure or to the maximum kind of medical capability. You also said that people aren't seeing a cardiologist. I mean, most of us go to the dentist, we go to our primary care doctor, women will go to the OBGYN, but when should you go to a cardiologist? When do you know to go?
Well, I think that so I mentioned high blood pressure, and I don't think necessarily mean that only a cardiologist can treat high blood pressure, right? If 1 in 3 Americans have high blood pressure, there are barely enough doctors to take care of everybody with high blood pressure if we let all the doctors take care of them, if there's that many, right? 100 million people with high blood pressure, presumably. So people who have difficult to control high blood pressure, they should probably be seeing a cardiologist.
Okay.
If people who've taken 2 medicines and are not at their goal, and so what's the goal for high blood pressure? An ideal blood pressure is 120/80. And once the top number is over 130, that qualifies as having high blood pressure.
Can you take my blood pressure right now by my pulse?
No, I cannot.
Okay. Okay.
So I mean that some people have been prescribed medicines, but they are not yet successfully getting themselves down to 120/80 when they're not getting the goal.
So what are 3 things we can do right now, today, to help us reduce our risk of developing one of those kinds of heart disease?
So it shouldn't surprise anybody to know that the 3 things that we should do are exercise regularly, right?
What's that? It's like 5 times a week?
You know what exercise is. Exercise when you get up and move around instead of just sitting here in this chair. That's exercise. You have to get up, but you do not have to join a gym or become a power lifter or run a marathon, right? If you do 30 minutes of walking 5 days a week, a moderate intensity activity like that, you could still be able to hold a conversation while walking. So it doesn't have to make you breathless. That's enough exercise for you, okay? So you should do exercise.
Okay.
Many of us should lose weight or pay more attention to our diet, right? So I think that's important. And know what our blood pressure is.
Okay.
And make sure that if we have high blood pressure, get that under control.
Okay.
If I can go further, if you smoke, you have to stop smoking.
Right.
Yeah.
Right. And vaping.
Well, vaping, I think we know a lot less about vaping, a lot less than we want to know about vaping. Of course, I think it's been in the news these days. We don't know exactly the correlation between vaping and heart disease. We don't necessarily know what all the bad actors are in tobacco or conventional cigarettes that make them an important risk factor for heart disease. People who smoke have 4 times, not 4% more, 4 times the risk of having a stroke, having peripheral arterial disease, maybe to the point where having to have a foot or limb amputated. So, and having coronary artery disease, having a heart attack. We don't know whether vaping has that same risk,
Okay.
but we don't know that it doesn't.
Mm-hmm. Okay. So I just want to move on to women and heart disease. We have, I think, February the 7th is Wear Red for Women, to raise awareness of heart disease in women. And because I think when you think of a heart attack, the examples you gave, and if I think about it, I think of Bill Clinton having a heart attack, Bernie Sanders. It's often a man clutching his chest that comes to mind when you say someone having a heart attack.
That's not wishful thinking, is it?
No,
okay.
Not yet. But women, it's called the silent killer of women. And I think people think that it's because there's not as much awareness and understanding of heart disease amongst women than there is amongst men. So I've got some myths here. There's 5 myths about women and heart disease. I wonder if we can bust right here, right now.
But thank you for saying they're myths, because now I know they're going to be false. I'll get these answers right. Okay. Go ahead.
So, so more men have heart disease than women. That is not true, correct?
That is not true. In fact, more heart attacks occur to women than occur to men.
Okay. So it kills more men than women.
Again, that's not true. Women are more likely to die from their heart attack, and more women die of heart disease than any other cause of death.
But women are at risk more at risk from other things like cancer, for example.
Well, men and women are also at risk for having cancer. Mm-hmm. And some of the habits and some of the, like smoking and poor diet and being sedentary, place an increased risk for cancer as well.
Okay.
But heart disease is the #1 killer for men and women. Heart disease kills more people than all cancers combined. So although I think it's maybe more prevalent in the consciousness of women are more concerned about getting surveillance for the cancer that they may be at increased risk for, but heart disease is much more likely to kill them.
Are women more at risk after menopause?
So there is a certain protection before menopause for heart disease. And that's one of the questions that we ask when we're trying to assess women's risk, is at what age did you have menopause? Did you have menopause at a young age? Maybe some women have hysterectomies or have their ovaries removed for one reason or another in their 30s. And so they may be at increased risk for having heart disease then. So yes, before menopause, there is some protection against heart disease. However, that does not make you immune to having heart disease.
Okay. Do women recover better after heart attack than men after they've had a heart attack? What is their sort of rates of survival after their first heart attack? Are they better than men?
No.
No,
they're not. No, women may be at greater risk, and part of that may be related to treatment. Part of that may be related to this deferment of treatment that many times women, because of this history of people assuming that heart disease is not a problem for women. When women have shortness of breath or some chest discomfort, because they may be falsely reassured that this is not their heart, they may delay how long they take before they go see their physician, tell their family, come in to see somebody in the emergency department, and that delay may change their subsequent course. Also, unfortunately, until recently, I hope that it's been improving recently, the treatments that they got once they presented to a physician or emergency department may have been delayed relative to what men would get. Specifically, when they get to the emergency department, people may have looked for non-heart related reasons for the discomfort, so then delayed the heart-specific treatments they should have gotten, like getting an angiogram or an EKG, or instead of going for ultrasounds and chest x-rays, etc.
Right. So tell us what the signs are for a heart attack, typically, and are there any specific signs that women should be on the lookout for that are different to signs that occur in men? So
the classic description of heart attacks or heart pain would be a squeezing or crushing or pressure-like discomfort in the center of the chest. And I say discomfort because I've many times gone to somebody's bedside and asked, so are you having chest pain? And they say, no, it's not really that painful, but I have an ache or discomfort. Some people are having a lot of pain, but some people do correct me and say it's not painful because they associate pain with being something sharp like a knife. And when it's just sort of a ache or pressure or cramp, it doesn't quite strike them as pain. That discomfort is often associated with shortness of breath or getting sweaty, maybe feeling palpitations. That would be the classic description of chest pain. When people are having a heart attack, it comes on, they get the discomfort, and then it doesn't go away. Okay? Until they get to the emergency department and we do something that hopefully can stop it. Now, the atypical description of chest pain, and men may also describe their chest pain or their angina, their heart pain, atypically, but women are much more likely to use a less typical description of heart pain. In that case, the atypical descriptions of heart pain focus more on feeling short of breath, maybe feeling just nauseated. Many people come and say, no, I think I'm having heartburn or reflux, and it turns out that it's their heart. Some people may just get sweaty, or palpitations may be the predominant symptom for them. Those are and women are much more likely to use some or all of those descriptions and not have the chest pain or pressure be the central focus.
When you're having those symptoms, can you explain why it is so important to get care as quickly as possible? Why do you talk at home about seconds counting?
Right.
In terms of outcome?
Right. So there's of course there's a saying that time is money, but for the cardiologist, time is muscle. Okay. When the heart is supplied by arteries itself, by coronary arteries, and the heart attack we're talking about is when that artery becomes completely occluded, and the blood flow that should be providing, blood and oxygen and nutrition to the heart muscle is interrupted and stopped. And that's what the pain causes from the lack of blood flow there. So that heart muscle is dying without oxygen, without nutrition. And so with too long before we restore blood flow to that heart muscle, that portion of your heart muscle is going to be scar, and it doesn't regenerate. So that's why it's so important to get in quickly and open that artery up to restore blood flow.
Now, that's not in the cath? That's in the ER in the cath lab.
So you come to the emergency department. Hopefully, you've taken an ambulance to get to the emergency department as fast as possible. The great thing about working in this community is that we have a lot of great relationships with EMS, and so EMS notifies the emergency department ahead of time. We're coming in with somebody who we suspect is having a heart attack, and then we can start getting the cath lab ready and the mobilizing. And when I say cath lab, that's where we do a procedure called a coronary angiogram and an angioplasty, where we go in through an artery with a small tube, pass it up to the heart, take some pictures of the heart arteries to find out exactly where the blockage is that's causing the heart attack, and we open up that blockage with a balloon and then a stent, which is a small metal coil that acts as scaffolding to hold the artery open. So the procedure, we do that procedure in the cath lab. It kind of looks like an OR, but cardiologists think we're special, so we give it a special name. But you should come in through an emergency department and get that ball rolling, if you will.
And sometimes you talk about the difference in outcome between just say 90 minutes and 2 hours. You say there's even a difference.
Right, so we measure something called the door-to-balloon time. From the time you enter our door to the time we get a balloon open up in the artery. And we have a goal to get that artery open as fast as possible. And from the time you come into the ER, you get in that lovely hospital gown, you have your EKG, the ER doctor sees you, we see you, and we get you into the procedure room, do the diagnostic angiogram and get the artery open. We want it to be under 90 minutes. There have been several studies done looking at revascularizing, supplying blood flow again to the heart muscle, and show that there's a difference between 60 minutes and 120 minutes. The people where it took 2 hours, as opposed to just 1 hour, the risk of dying was 1.4 times the risk compared to people who got their artery open within 1 hour.
Wow.
And so that's why we want to get that done as quickly as possible. And that the curve sort of crossed there at about 90 minutes, which is why we set the goal at 90 minutes, because to make sure that we don't approach that 2 hours where the mortality risk really goes up.
So if you're in East Hampton, you're in Sag Harbor, you have to get to the Southampton Hospital to get into the cath lab, if you're having a heart attack.
You have to go to the closest emergency department possible, get identified about what the best way to treat you is, and we'll do the procedure right then and there. Exactly.
Okay. So just going to switch gears. Fortunately, we've had some questions from some people. It is Valentine's Day in February also, and there's been some very famous examples of broken hearts. Carrie Fisher died, I think her mother died 1 day later. I think Kate Spade, the designer, died, and her father died a few hours before her funeral. There's many examples. I think people know of couples too who have died within a short time. Can you die of a broken heart? We've got a couple of questions to get through, but let's just try and take these quickly from our viewers.
So the short answer is yes, you can die from a broken heart. There's a very specific type of cardiomyopathy, of heart muscle dysfunction, that happens after situations like this. And it doesn't have to be necessarily the loss of a loved one, but that's the classic example. But yes, there is a cardiomyopathy associated with that. There's actually a much less romantic name for it, actually.
We don't want that. I'm just kidding.
Okay. All right, good. It's called Takotsubo cardiomyopathy, and the Takotsubo is a Japanese word for octopus pot. But Hallmark is not making octopus pot cards. So
okay, let's move on. So we have a question. During the winter, my dad insists on shoveling his own driveway. He's now 70 years old. Is this putting, moving the snow, is this putting a strain on his heart?
Maybe. I don't know your dad, right? I don't know their dad. But so shoveling snow is a classic potential risk for having a heart attack. Now, the reason for that is there are many people who don't get much exercise, and when there's a lot of wet snow out there, that's a lot of exercise for people who are not used to doing it, which raises their blood pressure. The cold air also increases that risk. And so, yes, people can have a heart attack while they're shoveling snow. Now, if mom or dad is a healthy, robust 70-year-old and is used to doing that kind of work, then it's probably not bad for their heart.
Okay. So we have here some red wine from one of the lovely vineyards out here. We're blessed with wonderful vineyards and wonderful wines. The question is, I love red wine. I understand it is good for your heart. the resveratrol, right? I think is it that's good for your heart. The question is, how much is too much, and how much is good for you?
Oh, well, I'll take the second question and leave the first question. But a glass of wine a day for a woman is the right amount of alcohol, red wine, that's good for their heart. Men may get away with 2 glasses of wine a day, but truthfully, a glass of wine a day is good for your heart.
So 1 glass a day is really
a glass a day is sufficient to give you the benefit that you want.
Okay.
And it may not be enough benefit that if you don't drink to start drinking, but a glass of wine is good for you.
So I have a question here about clams. We love clams out here. We go to clam bakes. I'm worried about the cholesterol in the clams.
Yeah, well, shellfish are sneaky little guys. Shellfish have a lot of cholesterol in them. And I had to look it up when we were living in Louisiana about the crawfish down there. And it turned out the crawfish had the total daily allowance of cholesterol in just 5 crawfish. But when our friends were having crawfish boils, they had a whole pound of crawfish allotted per person. No, maybe more, but at least a pound of crawfish per person.
Right. That's true. Okay, well, unfortunately, that is all we have time for today. There will be a new episode coming soon. Thank you, JP, for coming and telling us about all of that. Like I said, we will be tackling other key issues in the next episode, so please send in your questions to us, and we look forward to seeing you again. And thanks to everyone at LTV for this new program, the Hamptons Health Hotline.